So we're going to start with the essential plan. The essential plan is a really cool thing that we pretty much only have in New York. When the Affordable Care Act was passed, it included an option for states to create what's called a basic health program, and only two states decided to take that option. One of them was New York, and we call our basic health plan the essential plan. It provides comprehensive health insurance through managed care benefits, through managed care plans, and you enroll in it through NYSO, the New York State of Health. There's 4 types of essential plan called creatively 1, 2, 3, and 4. And which one you're in depends on your income and your immigration status. There is a 5th category of eligibility for essential plan, and that's for people who make 200 to 250% of the federal poverty level. Unfortunately, as things stand right now, and as I think you probably all know from our monthly meetings over the past few months, as of July 1st, 2026, that last category, people making 200 to 250%, is going away. And the folks who are in that category will have to find another type of health coverage. This is part of the fallout from the changes at the federal level. So essential plan for eligibility. People are eligible for EP or essential plan if they're not eligible for Medicaid, Child Health Plus, or what's called affordable minimum essential coverage, like an employer-sponsored insurance or Medicare. Age 19 to 64. The minimum age 19 is there just because anyone who's under 19 is eligible for CHIP. New York State resident, you have to meet the income requirements, and you have to meet the citizenship and immigration requirements, which we will talk about. And you also have that great chart in your folders. And also for folks who are online, the chart is in our, is it in our portal? Yeah. It's in our portal, and we've distributed it at the monthly meetings too, but Geneva, if you're able to, maybe you could pop it into the chat too, just for, oh, Sam is dropping in the chat. And again, as of, or starting July 1st, that 1/5 category of essential plan eligibility is going to go away. So this is the eligibility requirements for the essential plan. So let's talk about essential plan eligibility for non-US citizens. Most immigrants qualify for the essential plan if they meet the other eligibility requirements. So like being a New York State resident, not having other coverage, income requirements, etc. So people who are non-citizens are eligible for essential plan if they are what's called a lawful permanent resident, if they are lawfully present, or if they are in a valid non-immigrant status, like having a valid visa. Lawfully present is not an immigration term. It is only used to classify whether non-citizens are eligible for certain benefits. It's defined in the Affordable Care Act or the ACA. Generally, if someone is not eligible for Medicaid due to their immigration status, they will be eligible for Essential Plan 3 or 4. There is a smaller group of folks who are out of status or undocumented, who are only eligible for emergency Medicaid, which Sam mentioned in her presentation. But in New York, luckily, most non-citizens, if they're not eligible for Medicaid, are eligible for Essential Plan. Helpful resources. Oh, here's the link again to the chart that's in your folders. And also the New York Immigration Coalition has a chart on immigrant eligibility for public benefits in New York State that talks about health insurance and other public benefits, but just note that it does not, that NYIC resource does not yet account for the changes made by the federal government in HR 1, also known as the One Big Beautiful Bill Act. Please contact us if you have any immigration questions, clients with immigration needs. Our enrollment folks are super familiar with the immigration rules for insurance eligibility, and we can also help with referrals for other immigration issues that might not be health insurance related. So feel free to reach out. Okay, Aliasa immigrants. This word Aliasa just comes from a court case around immigrant eligibility for insurance. And basically, so these groups of immigrants are referred to as Aliasa immigrants because they are eligible for coverage. So Aliasa immigrants are what's called qualified aliens who are still within that 5-year bar. So some of you might recall from our most recent training or other trainings that even immigrants who are eligible for Medicaid have a 5-year bar. So they're not eligible for the first 5 years of being a so-called qualified alien. So if you are working with an immigrant who would be eligible for Medicaid, except that they're still in that 5-year period, they would be eligible for the essential plan instead. Lawfully present, so again, that's the term that's just used for benefit coverage determinations. Lawfully present immigrants permanently residing under the color of law, also known by the acronym PRUCOL. Those folks are eligible for essential plan, and then what we call PRUCOL only immigrants. So those are immigrants who are not considered lawfully present, but who well, I won't get into the details of PRUCOL right now. We do have a whole training on immigrant coverage on the portal. Those folks are eligible for EP, Essential Plan 1 or Essential Plan 2. The exception is if someone is in one of these immigration groups and they are a child under 21 or a pregnant woman, then they are actually still eligible for Medicaid. And please feel free to shout out questions as I go if you would like to. I will do my best to answer them. So the essential plan is, like I said, is a comprehensive benefits package, and it covers the so-called essential health benefits that were created by the Affordable Care Act. And they include all of these services, most notably for us, mental health and substance use disorder services. Lawfully present Aliasa immigrants who make less than or equal to 138% of the federal poverty level. So they're in the Essential Plan 3 or the Essential Plan 4. They get additional benefits, and to access those benefits, this is so confusing to me. They're going to get their Essential Plan card, and then they're also going to get a New York State Medicaid card, even though they don't have Medicaid. So they're going to use their Essential Plan card for non-prescription drugs. These are the additional benefits: orthotic devices, orthopedic footwear, vision care, and dental. And then they're going to have this Medicaid card, even though they don't have Medicaid, that they can use for non-emergency medical transportation and family planning and reproductive health services. So sometimes you might be working with somebody who has the New York State Medicaid card, so not a card from like Fidelis or another managed care plan, but the state one. And you and they are confused about whether they have Medicaid or not. And if they don't have Medicaid, but they have the card, it's probably because they have this essential plan coverage. The cost of essential plans. So again, back to the federal poverty levels and how these affordability options are determined by household income. You can see here that for the different 1, 2, 3, 4 essential plans, the cost is dependent on how much household income somebody has. A lot of these cost sharing, a lot of these plans now have 0 cost sharing, which is amazing. For mental health and substance use disorder outpatient services, copays should be the same as whatever the plan's copay is for a PCP visit, which is also great. And there's a link here to like the full list of cost for essential plan coverage. And just really quickly, these are not specifically, obviously, mental health or substance use disorder conditions, but nonetheless, impact many of our clients. So with the essential plan, There are zero out of pocket costs for pregnancy and postpartum
Hi, my name is
services.
Geneva, calling again from Champ. I just hoping
Geneva,
someone could reach out to
Geneva,
me. My
Geneva,
number
mute
is
yourself.
212
No,
614.
can you mute her? Yeah, she's got it. She's got it. She's manning the helpline. Okay, so there's also been added essential plan coverage for 8 doula visits. And there's no copays for during pregnancy and postpartum up to 1 year. And that's not just no copays for pregnancy and postpartum specific services. That means if you're like if you're pregnant or in that 1 year postpartum period, also no copays for your mental health substance use services. So it's just a good thing to keep in mind if you're working with clients who are pregnant or postpartum. In the essential plan, also zero out-of-pocket costs for certain diabetes services listed more here. Just something to know about if you're working with clients who have diabetes, in addition to whatever issues you're helping them with. Child Health Plus.
Question.
Yes.
So for those essential plan holders that also have the Medicaid card,
Mm-hmm.
would that show up on EPCs? Because I've seen EPCs that says family planning only. Something
That
to
is
that effect.
such a good question that I don't know the answer to. I'm not sure. Okay. Sam thinks so. Pam's question for people on the Zoom is whether for folks who have essential plan and they also have this New York State Medicaid card for their additional benefits, whether that shows up in e-pieces. Sam thinks yes, but is checking. Because Pam said she has seen people in e-pieces where it says family planning only. So, I mean, that would make sense. We'll see what Sam finds. Thanks, Pam. Any other EP questions before I move on to Child Health Plus? All right. Child Health Plus eligibility. So all children who are New York State residents and are 19 or younger are eligible for Child Health Plus. There's no citizenship or immigration status requirement. Currently in New York, we have what's called continuous coverage from ages 0 to 6. So we're going to talk next. We're going to go back to FPL's federal poverty levels and how that impacts the affordability options for CHIP. So there's just one income level, the highest income level, where someone would have full pay, what's called full pay CHIP. For everybody else, there's continuous coverage from ages 0 to 6. And we'll talk about this again on the next slide. Yeah. The answer is yes. Sam says the answer to Pam's question is yes. Folks with EP, essential plan, and the Medicaid card will show up in e-pieces as family planning only. Cool. Great question. Thanks. I didn't know that. Okay. Continuing on through the eligibility requirements for Child Health Plus. Folks are eligible if they don't have other health insurance coverage, unless they're 0 to 6. So this is relatively new, where kids ages 0 to 6, even if they have other health insurance coverage, can still enroll in CHIP. And there's this like state health benefits. They're basically saying the same thing. Sorry, those two sub bullets are no other health insurance coverage or no coverage through NISO, unless they're age 0 to 6, and then they can have other health coverage and also CHIP. There is an income chart that desk aid that I mentioned that you'll have in your folder, where you can see the eligibility requirements, income eligibility requirements for CHIP, and what the corresponding cost of CHIP is based on income. So there's a sliding scale premium in CHIP based on modified adjusted gross income, or MAGI. But it's important to remember that any child that is not eligible for Medicaid in New York State is eligible for CHIP. And you apply for CHIP through NISO. So essential plan through NISO, CHIP through NISO, most Medicaid through NISO. And then just a note, the continuous coverage for subsidized CHIP might end depending on the outcome of the current state budget negotiations, but we will, of course, let you know if that happens. Benefits. So CHIP is delivered through managed care plans. There are no deductibles or copays for services under CHIP. There is, for everyone in CHIP, 1 year of continuous coverage, meaning even if household income changes, you maintain your coverage. For kids 0 through 6, they have continuous coverage 0 through 6, even if income changes. CHIP coverage includes all the things listed here, which include mental health and substance use services as well. For newborns, newborns are covered by CHIP effective the first day of their birth month. So like if a child was born on December 15th, their coverage starts December 1st. And they're determined eligible within 60 days of their birth so that there's no gap in coverage. If the newborn has siblings, they are automatically enrolled into the same plan as their siblings. If they do not have siblings, then the parents would or guardians would select the plan and the start date. And here's the cost. So you can see that for kids where the household income is less than 220% of the federal poverty level, CHIP is free. No monthly premium. And then the premiums start at 222% of the federal poverty level, and they go up from there. And then that last group that I mentioned earlier, where folks make over 400% of the federal poverty level, they are full pay. They pay the full premium. No subsidies and no affordability options. Any CHIP questions before I move on to qualified health plans? All right. This little picture here is because qualified health plans were created by the Affordable Care Act. These are the commercial insurance plans that are sold on NISO, so on the health insurance exchange or marketplace in New York. These plans, like CHIP and Essential Plan, are provided by managed care companies. They're also purchased on NISO. They also have to cover the 10 essential health benefits, which includes mental health and substance use disorder services. This is not something I understand well, but qualified health plans have tiers. You've probably all been hearing about them ever since the Affordable Care Act was passed. There's platinum, gold, silver, and bronze. Platinum. So the tiers are based on actuarial value, which is the percentage of total average costs for covered benefits that a plan will cover. Like I said, this is not my strong suit, but the arrows here. So, and you all probably know this from, working with clients, reading the news, etc. So with the higher metal levels like platinum and gold, you're going to pay a higher monthly premium, but your out-of-pocket costs will be lower. And then when you get down to the lower metal levels like bronze, your monthly premium is lower, but your out-of-pocket costs are higher. So it's the trade-off that people decide on when they sign up for one of these plans. And then there's also catastrophic plans. These are very high deductible plans that are for folks who are under 30 or who have what's called a hardship exemption. And I don't think we have a whole lot of folks with catastrophic coverage in New York anymore. So as I said, qualified health plans, also known as QHPs, you enroll through NISO. Coverage has to be renewed annually. Folks enroll into a managed care plan, either an HMO, health maintenance organization, EPO. No. I actually have definitions later. And PPO is preferred provider organization. PPO is very rare. Those are the plans with out-of-network benefits. That's very, very, very rare in a qualified health plan, but apparently does exist.
Exclusive provider.
Thank you. EPO is exclusive provider organization. Thank you. I also remembered from trivia the name of the country I was trying to think of. It's Bhutan. Bhutan. I'm not sure how you. They have a national happiness index, and they seemed like a country that would have a unicorn as their national. So anyway, that's I'm getting there eventually.
It's also gonna say, this is not a science, the AV,
Actuarial value.
One way to think of it is, it's the value you get out of the plan. So it's, you pay more, but the plan also covers more.
Thank you. Sam, for the folks on Zoom, says another way to think of actuarial value is the value you get out of the plan. You pay more, but you get more out of it. Yeah. Thank you. Okay, and when you enroll into a qualified health plan, as I think most of you know, coverage begins the first day of the following month. If you enroll by the 15th of the month, if you enroll after the 15th of the month, then your coverage begins on the first day of like the second month. So if we're in May now, right? So if I enrolled today before May 15th, my coverage would start June 1st. If I enrolled on May 20th, my coverage would start July 1st. Switching plans. Qualified health plans, folks can only switch their plan during the open enrollment period unless they qualify for a special enrollment period, also known as an SEP. Open enrollment is usually November through January. It might be shortened as the impact of the federal changes rolls out, but it historically is usually November through January. And then special enrollment periods happen when somebody has a qualifying life event outside of the open enrollment period. So this is things like losing other health insurance, moving to New York, a marriage or domestic partnership, or a divorce or legal separation, pregnancy, birth or adoption of a child, or a child placed into foster care, becoming a citizen, national, or lawfully present, or becoming eligible or ineligible for help paying for a qualified health plan. If somebody has one of these qualifying life events that makes them eligible for a special enrollment period, they have 60 days from that event to switch plans.
People in 200 to 250 have a longer.
Sam says people in EP 200 to 250 have a longer period after a triggering event to switch plans. Thank you. And I guess I should have mentioned when we were talking about EP, and I didn't, in talking about the option for the essential plan for people making 200 to 250% of federal poverty level, and that is going away July 1st. There is, as I think probably many of you know, a large advocacy campaign happening right now to try to get the state to fund coverage for that group of people. So it's about 450 to 500,000 New Yorkers who will lose their essential plan coverage July 1. So it is possible that the state will decide to do something about that loss, but currently they will lose that coverage. Okay, so this is the affordability piece of qualified health plans, which is called premium tax credits. So premium tax credits are federal tax credits that are applied to reduce QHP premiums, the monthly premiums. It's called the Advanced Premium Tax Credit, or APTC. People who are eligible for this tax credit can use that money in advance. That's why it's called an advanced premium tax credit. So they can use that money when they enroll, or they can claim it later on their tax return. It's based on household income and household size, and is available to people with income below 400% of the federal poverty level. This is also in that desk aid in your folders with all the colors. You have to file taxes for the year the credit is received. If you don't, you might not be eligible for a tax credit in the future. And then unfortunately, as of January 2026, the enhanced premium tax credit option that used to exist went away as a result of the changes at the federal level. So that means that people with household income of 400% of the federal poverty level and above no longer can get those tax credits. Qualified health plans also have extra benefits. I'm not sure if that's quite the right word for pregnancy, postpartum, and diabetes. So for all qualified health plans, there's zero out-of-pocket costs for most diabetes services, just like with the essential plan we were talking about earlier, and also zero out-of-pocket costs for most pregnancy and postpartum health services. That, like the essential plan, that goes up to 1 year postpartum. It applies to everything except hospital services. So, just looking to see, you can read that list yourself. Notably, this does not apply to ambulance services, inpatient services, emergency care in a hospital, or delivery of the baby, which is wild. So you still have to pay to actually deliver your baby, but we'll take what we can get. All these other services are zero out-of-pocket costs for pregnancy and 1 year postpartum. Okay, that's all. So that's all qualified health plans. There's one type of plan, qualified health plan, which is the silver plans with cost sharing reduction, or CSR, that offer even more savings than the regular silver plans. They discount your cost sharing payments. Cost sharing includes deductibles, co-payments, and co-insurance. So if you sign up for one of these plans, those costs go down. And there has recently been expanded eligibility for Silver Supreme CSR plans. I'm trying to decide whether to read all of this to you or just let you have this information here on this slide and in the portal. I think you can probably just see it, but just know that there are these silver plans with extra benefits, and the eligibility was somewhat recently expanded to people with incomes up to 350% FPL, and for one of them up to 400% FPL. So changes to qualified health plans resulting from the federal legislation known as HR 1, also known as One Big Beautiful Bill Act. These are changes to immigrant eligibility and coverage. The first one that hit us was August 2025, so we've already been through this, which is immigrants with deferred action for childhood arrival or DACA status lost eligibility for those premium tax credits for qualified health plans. Those with incomes under 250% of the federal poverty level will be covered through July 1st of this year. And then if they're income eligible, they'll continue to receive Medicaid funded fully by New York State. So for those of you who were around when we went over some of the changes to immigrant coverage at one of our monthly meetings, you might remember that one of the wonderful things about being a New Yorker is that our state is using its own funds to fund Medicaid coverage for a lot of groups who are losing eligibility for federal coverage. So that's the DACA folks who lost eligibility for tax credits for qualified health plans, but if they're income eligible, they can move into state-funded Medicaid. Effective January 1st, a bunch of other immigration statuses, January 1st, 2026, so this year. All these immigration statuses for folks below 100% of the federal poverty level lost their eligibility for advanced premium tax credits. And then January 1st, 2027, these same immigration groups, but with incomes over 100% of the federal poverty level, will also lose their eligibility for advanced premium tax credits for qualified health plans. So I would say, you know, the takeaway for immigrants, it's becoming much harder or impossible for many groups of immigrants to get these affordability options for a qualified health plan this year and next year. Any questions on that before I move on to employer coverage? Employer and union sponsored insurance. Am I doing on time? Okay. So employer or union sponsored health insurance is health insurance provided by an employer or a union to its employees or members, and sometimes to their family. It's administered by a health plan, so you know, your Aetnas, Cignas, Uniteds, and it is important to find out what kind of plan someone has in order to understand their benefits. So nothing is simple about health insurance in the United States. When it comes to employer and union sponsored health insurance, your employer decides whether their coverage is what's called self-funded or what's called fully insured. You, the person who has that insurance, probably wouldn't know which one you have. Although New York now requires, if your plan is fully insured, that your insurance cards say that. So if you are working with somebody who has employer coverage, you can ask them to look at their card and see if it says fully insured or fully funded. The reason it's important to know whether the insurance is self-funded or fully insured is because that changes what laws govern the insurance. Self-funded health insurance is subject only to federal law for the most part. Fully insured plans are governed by New York state law. Why does this matter? As you will see tomorrow when we go through a bunch of New York state law stuff, health insurance that has to follow New York state law has a lot more protection for the consumer. So you want to know which kind of plan your client has. So to find out which one it is, they can ask their employer or their union. I will say, I don't know that we've ever seen like a fully insured union sponsored plan. So if you're working with someone who's got union coverage, it's probably self-insured. And then you can check the card because if it's fully insured, the card is supposed to say so. There are some nuances to this that are beyond the scope of this training. Okay. I did put this here. So you also want to know what type of plan they have. Health maintenance organization or an HMO has a network of providers. Members choose an in-network primary care physician. They might need a referral from that PCP to get services from other in-network providers, and care with out-of-network providers is usually not covered. There's an asterisk there that it looks like might not have a counterpart on this slide, but is probably referring to out-of-network referral rights, which we'll talk about more tomorrow too. So there are pathways to out-of-network coverage, but generally it's not covered. The exclusive provider organization or EPO also has a network of providers. Some services might require prior authorization. Out-of-network care, usually not covered, again with that asterisk. Preferred provider organization or PPO, these are the plans that do have both a network of providers, but also out-of-network coverage, usually at higher cost. And generally there's no referral needed to see a specialist. Point of service or a POS, I feel like we don't really see, but it's similar. It has some similarities to a PPO and an HMO. And if you see it, just Oh, gosh. What did I do?
Oh, what's happening?
I don't know.
Where did the PowerPoint go?
I don't know.
Oh dear. That was weird.
That's weird. I feel like maybe my,
I think my computer's deletion of things is contagious.
is this yours or the loan?
They look, no, this is the loaner. I think you were on 45.
Oh, thank you. Memory.
Well, I went to go see if the aspect had a thing.
Oh. Um, okay. Yeah, you can get back to where I was. Awesome. Thank you.
Hit this because I'm gonna have to switch it.
Hit what?
Oh, hold on. We have to reshare. Sorry, guys.
Sorry.
Where did the screen share go? Oh. Ah, here it is. Yay.
Thank you, Sam. Okay. Let's see. Hopefully that won't happen again. Denials. Um, so, commercial insurance denials. Usually they must be in writing. They might be based on things like not having a prior authorization, not being medically necessary, missing certain documentation.
Here's what we're gonna do.
This
I'm
is-
gonna share the slide deck from my computer.
Oh, okay.
Geneva,
Yes,
could you make my account co-host?
I
Oh wait, I
can.
can.
I think that it can only be made you can only make something co-host.
You're right.
A host
You're
miss
right.
make because I tried to with Billy earlier.
Oh, okay, here, I'm gonna make.
This is where having a printout
Uh-huh.
would have come in handy. I should have printed the slides.
No.
No, it's fine. Don't worry, we'll fix it. Everything's fine. All right. I'm gonna minimize these guys. Yeah, for some reason it doesn't like it's not cooperating. So I'm gonna just share this from my computer and they can hear you through it. If it ever reopens. Like the real life spinny wheel.
Yeah.
You know, I was gonna print these for you and didn't.
I also. Yeah. You have thoughts.
No. It's okay if you do have thoughts. Okay, here we go.
Good time for a post-lunch caffeine break.
Yes, if anybody needs to caffeinate, now's the
Still
time.
have time to sit through training. Should I? Oh,
So you're controlling the slides in this room and Sam's gonna control the slides.
okay.
But still talk close to the laptop so that.
Okay, and tell you next slide? Or can I
And then
advance?
also we
Advance.
can't see it. I
I'll
don't know
follow
if
you.
that maybe is not possible given the current technological environment we're living in.
Geneva says they can't see it.
I did check.
Okay,
Oh,
okay.
she didn't
Okay.
share it yet. All right. Well,
Uh,
I'll just in the in time to suspend. Okay. All right. I will, let me see.
that is perfect. Thank you.
You can see it?
Yes.
Okay, but I can advance it still, that's okay?
Yes, I'm just
Okay.
gonna follow you.
Oh.
Yeah.
I don't understand, but I have faith. in you.
Separately.
Okay,
I'm
I'm just here doing my own thing. Okay.
Says I'm not doing it.
All right, let's keep it going. Right, when you get a denial, if an insurer denies coverage, there's almost always going to be a right to a grievance and or an appeal. Internal appeals are appeals to health insurer. External appeals go to an independent review organization after internal appeals are exhausted. Most denials that are based on medical judgment come with the right to an external appeal. Again, if you get a denial, if you have a client who might have an appeal right, just reach out to us at CSS and we are happy to work through that with you. It is very important anytime a client shows you a denial notice or says they have a denial notice to look at that denial notice and figure out if they have appeal deadlines, because if they miss the deadline, they use the right to appeal. And again, we can help with that. Yeah, you're with me. Okay, so contact information is there. Common issues. So the first common issue is out-of-network referral rights, which I kind of referenced earlier. This is one of those reasons why having a plan that's governed by New York state law is generally better for the consumer than having one that's only governed by federal law. I just got a message saying that my computer has successfully updated.
Oh, great.
So that's why it was closing. Can't
see it.
Okay, well, that's good. All right. So one of the things that all New York governed plans have is an out-of-network referral right. This is important to CHAM clients in particular, as you all probably know, because folks experience such pervasive issues with networks for mental health and substance use disorder. It is so hard for people to access in-network care. So it is good to know about this option. In New York, if somebody cannot find in their network a provider with the training and experience to treat their specific health condition and who is able to provide the services that they need, they have the right to what's called an out-of-network referral. That means that they have the right to go to an out-of-network provider at no cost to them beyond their in-network cost sharing, even if they don't have out-of-network benefits. However, you have to request this from the plan before going to the out-of-network provider. Sometimes people are like, oh, I couldn't find anybody, so I just went out of network. Which makes sense logically, but is not how you get this right. If the request for an out-of-network referral is denied, there's a very specific appeal process that people can go through. So reach out to us at CSS and we're happy to help with that. And we also have a full training on out-of-network referrals available in the portal. Okay, so case studies. Sylvester. So I'm always just amused by the names in the case studies because a lot of us use like television shows and things to come up with the names, and I'm just curious if Geneva was reading Sylvester and the Magic Pebble when she created this, but it's probably something else. Sylvester informs you that he has the essential plan and has been paying $15 copays each time he's treated by his therapist, and he wants to know if that's correct. He's having trouble paying for his treatment and wants to know what else he can try. What questions might you ask before you can help? And we're not doing groups for this one, so you can just shout it out. Would you ask Sylvester?
Can screen them for life insurance, qualifies for LBG.
Yes, Miriam says you could screen him for other coverage to see if he qualifies for something cheaper. And to do that, we would ask about income, right? And household size. What was that?
Health size,
And
work status, income.
Miriam says immigration status, income, household size, refer him to CNN for screening. All great ideas. Anyone else? Any other ideas?
Sliding scales. That
Yes.
provider to see if they're willing to do that.
Absolutely. Terry says sometimes sliding scales or even free services. Thank you. were you gonna say?
I have a,
Oh, yes. Who? Oh, I
no,
can't
I
see.
was going to say I would also maybe contact New York State of Health to reevaluate to look at his income again to see if he might, get something other than the essential plan.
Yes, thank you, Marguerite. Marguerite's also saying, um, check his income, see if he's eligible for something else, that might be more affordable to him. Marguerite mentioned NISA, as being a place that could help with that too, as well as, the navigators. Thank you, Marguerite.
I would ask which essential plan, because is it better to remember it correctly? I think some of them have $0 copays, so like understanding which plan and then looking at that list to see like, is that correct for the essential plan?
Yes, absolutely. Laura said another reason to ask about his income, and also ask which essential plan he has, 1, 2, 3, or 4, is because different essential plans have different cost sharing, and he might be eligible for one of the zero cost sharing essential plans rather than one with a $15 copay. So they're all such good ideas. Anyone else?
I just have a question.
Yeah.
Yeah, I was working with a client that had the essential plan. Now she has a card that says $0, no copays, but she's being charged copays. I mean, I'm going to be investigating that. I'm meeting her this week, but I was just confused about that.
So, ooh,
Oh, I got it.
no, it's-
Does a card have a number on it, Marguerite? Like EP 1, 2, 3, or 4?
I don't know. I haven't seen her card,
That might help explain. Maybe.
but she wasn't being charged all this time. Then all of a sudden, unless something changed, I don't know. But it was just bizarre to me. I never came across anything like that before.
right. So the client has an EP card that says zero cost
Yeah.
sharing, but is being charged cost sharing.
Yes.
Yeah.
I actually want to say that this whole case study is inspired by someone that I was actually working with, whose name was not Sylvester. But her provider just like messed up and she had a $0 EP and they were just charging her copays because they got it wrong. So that might be what happened, so like baseline, just making sure you know what EP plan it is and that it's all that the copays are correct.
Oh, wow. Okay.
Thank you, Geneva. Is that you or is that okay? I will also say I have a family member who's a Champ client, and we like to say that his NISO account is haunted because it just will like switch him. Like they just switched him from Medicaid to an essential plan for no reason that anyone can determine. So that was a whole thing, and then we got him put back into Medicaid, and
Oh,
then they said that, and Miriam was working with him. Then they said that he had a third party like pharmacy benefit, which he doesn't. And then that was a whole thing that Miriam worked on to get that sorted out. So that's just sometimes also NISO just does things for no reason that we can understand. So it might also be that they just switched him.
oh my God.
But I think, yeah, it sounds like maybe starting by calling NISO to see what they think his coverage is, would make sense.
Yes.
Thank you for raising that,
I
Marguerite.
feel like we're like investigators. It's like, oh, I dig
Yes.
I keep digging and digging.
Yes, I know that feeling. I am echoing.
Thank you so much.
Thanks, Marguerite. And this is so you all really nailed it. Ask which essential plan Sylvester is on. If he's on EP 2, 3, or 4, he should not have copays. And so you can help by informing his providers that they shouldn't be charging him. If he has essential plan 1, you can ask what his income and household size are and if it's changed since he applied. If his income is reduced, he might be eligible for Medicaid or EP 2 through 4. So you can connect him to an insurance navigator like CNN. And if not, he might be eligible for hospital financial assistance if his services are provided through a hospital. You also can ask if a provider is willing to forego collecting their copay if they can't afford it. Providers sometimes will agree to that. They can't do it in like a widespread way because then the insurer might say they're committing fraud. But sometimes they will do it like one-off if somebody can't afford their copay. Great job, everybody. Case study number 2. This might be our last case study for this, actually. Okay. Pauline reached out to a Champ CBO for help paying for inpatient SUD treatment. Her employer-sponsored insurance has a $5,000 deductible that she cannot afford. What information do you need from Pauline, and how might she be able to overcome this barrier? And you can just shout them out.
If she goes to an Oasis inpatient facility, then her insurance that she won't need to pay to use her employer insurance necessarily.
Yeah, that's a great point, Elisa. Elisa's saying, I'm not sure if everyone can hear, but if the client goes to an Oasis, there's sort of two elements here. If they go to an Oasis funded facility, they cannot be denied treatment based on their insurance coverage, ability to pay, or immigration status. There is no way to check whether a facility gets Oasis funding like publicly. So we just email Ryan Gallagher and ask him. Thank you, Ryan Gallagher. That doesn't mean that they have to provide care for free. It means that they have to negotiate something that the patient can afford. And then there's also the ATCs, addiction treatment centers, which are also Oasis facilities. And they provide treatment regardless of, is that me? That's my end. Okay. Regardless of coverage or ability to pay. Yes, Bradley.
I want to know if she's met any of her deductible yet.
Great question.
If the 5,000 deductible is specific to your SUD, or if it's medical SUD combined, because that would change the achievability of spending $5,000 to be there. I think we also want to know if her employer sponsor insurance is self-insured. What's the other one?
Fully insured.
And then I would call where she wants to go to treatment, because many facilities will negotiate price. Especially if it's unaffordable, and also community based organizations that do scholarships for treatment and sometimes recovery housing. So that's like a whole other network to get to.
I'm wishing I gave Bradley the microphone because now I'm going to try to repeat all of that. Bradley had a bunch of great ideas. He wants to know, did Pauline meet any of her $5,000 deductible yet? Does her plan have one combined deductible for mental health, substance use, and medical surgical, or does it have separate deductibles? Because if they were separate, that would be a violation of the parity laws that we're going to learn about tomorrow. Self-insured or fully insured, and scholarship programs that are available, and programs will often negotiate.
Yeah, any inpatient facility will negotiate.
Any inpatient facility will negotiate.
Then she can also set up a payment plan in negotiation with what she needs. And then so the rest is that same way. Facilities themselves will give scholarships, and then there are like local nonprofits that sponsor people that we treat that will help pay for recovery housing early on, and then
Excellent ideas. Thank you, Bradley. And I'm sorry to be cutting off our discussion because we're out of time, but I think that you all got most of these. I'm not sure if we talked about seeing if she was eligible for other coverage. Okay, we're